Thank you so much for having me. Okay, so I'm going to go ahead and get started. So what we're looking at here is the vestibular system. So it's also known as the inner ear. So what the main part that we're focusing on or talking about, I don't know if you can see my mouse, is this purple thing that kind of looks like a snail. So the round part of the purple thing is the cochlea. That's the hearing portion of the inner ear. And the circles, or this what looks kind of like a snail's head, is the vestibular system, and that's the balance portion of the inner ear, and that's what we're going to talk about a lot today. The vestibular system is a very sensitive system. It is a pressurized system, and it responds to and gives feedback about where our head and body are in space, and then works with our eyes and our other balance systems to help keep us upright. So this is the vestibular system, and kind of we'll reference back to this through our talk. And I've tried to include pictures because it can be kind of confusing. But a fun fact about the vestibular system is that it's so small, it could fit on the face of a dime. And it's pretty interesting to know that something that small can have such a profound impact on our day-to-day lives. So talking about dizziness. So vertigo or dizziness is the illusion of movement. So a lot of times vertigo and dizziness get used synonymously, but they do have a bit of a difference. So dizziness is kind of a more generalized term, and vertigo is true spinning. So imbalance occurs with vertigo. Imbalance, unsteadiness, things like that. Vertigo and dizziness are caused by dysfunction of the inner ear, infection affecting the inner ear, brainstem or cerebellar dysfunction, and general systemic conditions. Vertigo and dizziness occur in 23 to 30% of healthy older adults. And symptoms include blurred vision, eyes jumping, dizziness with head movements or eye movements, and imbalance that can lead to falls. So when we're determining the cause of dizziness, there's things that we like to keep in mind when we're trying to figure out where dizziness is coming from. I always tell my patients that dizziness is kind of like pain, in that there are a lot of different things that can cause dizziness. And dizziness, like pain, is an alarm to our bodies that something is out of whack, something's out of place. So when we're trying to determine where dizziness comes from, things that are helpful in kind of narrowing it down is the description of the dizziness, the length of time that you experience the dizziness, and that's a big one. That's going to kind of be the theme of what I'm talking about. Symptoms that are associated with the dizziness, such as imbalance, fogginess, cognitive impairments, things like that. And then as well as past medical history. So those four things kind of give us a clue as to maybe what could be causing the dizziness. So dizziness gets a lot of different names. Could be room spinning or lightheadedness, unsteadiness, imbalance, fogginess or whooshiness. And then a person feels like they're spinning. A lot of times I'll ask my patients to describe dizziness without using the word dizzy, because then that kind of helps narrow in that, oh, well, maybe it's a lightheadedness more than a true spinning or vertigo. And so the length of time that you experience dizziness is going to be really helpful in determining what is the cause behind that dizziness. And so I'm going to kind of use that theme throughout this talk. So if the dizzy episode is only lasting seconds to minutes, then that's something called BPPV, or benign positional paroxysmal vertigo. If you've heard of someone say that they have crystals in their ears, that's what they're referring to. And so and I'll talk about that a little bit more. I'll talk about each diagnosis a little bit more. Minutes to hours, we've got Meniere's disease, vestibular migraine, superior canal dehiscence, perilymphatic fistula, and a TIA or a stroke. If the dizzy episode is lasting for hours to days, now we're thinking about something like a labyrinthitis or a neuritis or an acoustic neuroma. If the dizziness is episode specific, then we're looking at maybe a presyncope or orthostatic hypotension or something called mal de debarquement syndrome. If it's a vague presentation where it's like, I kind of feel off all the time. I just feel off. And yes, it ebbs and flows, but I feel off all the time. Then we start to think maybe it's something called 3PD or persistent postural perceptual dizziness, or maybe it's a visual motion sensitivity. Maybe it's post-concussion syndrome. So something that affects a lot of seniors, post-concussion syndrome. A lot of times we hear concussion, we only hear about athletes, but a lot of our older adults get concussion and may develop a post-concussion syndrome. And then finally, something called cervicogenic dizziness. So I'm going to talk about all of these a little bit. Okay, so the first one is if this dizzy episode is lasting about seconds to minutes. And it's important to, someone may come and say, oh, I'm dizzy all the time. But think about when does it start and when does it stop? So if with dizziness lasting seconds to minutes, do you move your head in a certain position and you get really dizzy, but then it stops? That's probably BPPV. And that's one of the most common causes of dizziness. It's thought to be the cause of vertigo for 11% of individuals with Parkinson's. And it's the sensation of a true vertigo, this violent sort of spinning. We kind of joke that it's called benign vertigo, but there's nothing benign about it. But what it is it's caused by particles in those canals that we were talking about at the beginning. Little crystals, otoconia, become loose and make their way through the canals, and they displace some fluid in these canals, and that makes you feel dizzy when you move your head. And it's a mechanical issue, so that means every time you move your head a certain way, you'll experience that dizziness until it gets resolved. And I'll talk about treatment for all of these things at the end of the discussion. Okay, so now let's look at if dizziness is lasting for minutes to hours. So you've probably heard of Meniere's disease. Meniere's disease is caused by a buildup of fluid in the inner ear. So like I said at the beginning, the vestibular system is very sensitive and it's a pressurized system. So when we have changes in fluid or air or a displacement of fluid, we get these symptoms of dizziness. So Meniere's is a buildup of fluid in the inner ear, and it can cause fluctuating hearing loss, ringing in the ears. A big hallmark sign is the feeling of fullness or pressure in the ear. A nystagmus, which is eye jumping, imbalance, nausea, vomiting. And Meniere's attacks are highly variable in duration and severity depending on the patient. And a lot of times it starts in one ear, and it can progress to the other ear. Meniere's disease looks very similar to vestibular migraine. Vestibular migraine, it presents with similar symptoms or imbalance, dizziness. Individuals can have sensitivity to light or noise, that episodic vertigo that I was talking about, headache. And then the big differences that we see between Meniere's and vestibular migraine is patients with Meniere's will describe fullness in their ear and then progressive hearing loss. And we don't see that with vestibular migraine quite as much, if at all. These are rare, but I thought I would just talk about them. Superior canal dehiscence and perilymphatic fistula. So superior canal dehiscence is caused by a hole in the opening of one of those canals. So jump ahead. So on the left, you can see this is a superior canal dehiscence. So this is a viewed in version of those circular canals I was showing you. And so the opening causes pressure changes in the inner ear, and that because the system is pressurized, when we change the pressure, then we get these symptoms of dizziness. Individuals with superior canal dehiscence are going to be very sensitive to noise and pressure changes. A perilymphatic fistula is leaking of fluid from the inner ear to the middle ear. And so again, talking about that pressurized system, when we leak fluid, we have pressure changes and we get dizziness. Individuals with a perilymphatic fistula will notice that they're worse with barometric pressure changes. So, you know, they may have really hard problems if they're on an airplane, or if they're lifting something really heavy and there's pressure changes in their head. And so here are those pictures again. On the left is a superior canal dehiscence. On the right is a perilymphatic fistula. These are pretty rare, and we can treat them conservatively, and they can also be treated with surgery. But we'll talk about that more as we go on. Okay, so now we're looking at dizzy episodes that last hours to days. And we have something called labyrinthitis or neuritis. Both are essentially infections in the inner ear.
Hello, I have a question. We cannot see, are you showing another item? Because we can't see it. All we see is your face. We don't see anything your handouts. A part of your, are you showing us a graph or?
I'm showing a PowerPoint. You don't see the PowerPoint?
No, we don't see the PowerPoint at all.
Okay.
I can't see your PowerPoint. Anybody else seems to be.
Yes,
Can't see it.
Do you want me to go back then? I can restart.
Yeah, okay, there we go. There it is. Yeah.
Okay, let me go back because I think it's helpful to see.
We're going, whoa. Sorry about
Yes,
that.
thank you for saying that. No, thank you. Okay.
Okay. No
Some of us
Great,
did
thank
see
you.
it. We
you
did
see-
see it. We've already seen what you were going to do again. I'm just letting you know that.
Okay, so you have seen this.
I have. My wife, I have. I don't know
Has
if
everyone?
anybody else.
I have not, I just saw this one here, but I haven't seen anything since this one.
We've seen the whole thing.
Just
Okay.
one person had a problem.
Okay, perfect. Okay, then I'm gonna.
No, I only saw the first picture. I didn't see anything after.
Yeah, see, we haven't seen anything except the first picture. And then I think that's where we lost it. Okay, we see this
Okay.
now. The next picture. Go ahead.
I'll kind of go through it quickly then for those who have already seen it, but I do want to make sure that those who haven't seen it just get kind of a visual image of what I'm talking about.
All right, thank you.
So this is the inner ear, and this purple circular part, we're looking at the purple, right? And the circular coiled part is the cochlea. So that's the hearing portion of the inner ear. The where it says semicircular canals, that's the vestibular portion of the inner ear, and that's the balance center of the inner ear. So that area is where we're talking about, and we're talking about dysfunctions that happen to that area. So I talked about the causes of dizziness, which you kind of saw all that or heard all that. Time mattering. So I think another picture that's important to see is when we're talking about BPPV, crystals, the otoconia, they're made of calcium carbonate, so that's why they get called crystals. They get displaced in these semicircular canals. And when they get displaced, they move fluid in the canals, and that causes dizziness. And so every time you turn your head, the crystals get displaced and you feel dizzy. And so in order to resolve that, we have to move your head in certain positions to put those crystals back. But we'll talk about that more. All right, so let's see. Okay, Meniere's, I didn't have any really pictures for those, but I do think it's important to see the pictures for the superior canal dehiscence and the perilymphatic fistula. So on the left of your screen is a superior canal dehiscence, and that's basically a hole in the superior canal that causes pressure changes and makes you feel very dizzy. And then on the right is leakage of perilymph fluid into the middle ear from the inner ear. And so again, there's that change in pressure, and that's going to cause one to feel dizzy as well. Okay, so I think we're all caught up on the same, we've kind of seen the pictures now. Sorry about that. Okay, so now we're talking about dizziness that lasts hours to days. We're talking about labyrinthitis and neuritis. They're both essentially infections in the inner ear. The only difference between them is with labyrinthitis, you're going to have a hearing loss and you won't have it with neuritis, but it can be caused by a number of things. Currently, we don't have a good handle on what can cause labyrinthitis or neuritis, except for maybe an upper respiratory infection. I've had individuals present to my clinic who got it post-COVID, which was really interesting. But these individuals will present usually to the ER because they feel violently ill. They have violent vertigo, it's severe, they can't walk, they're throwing up, the room is spinning, and that lasts for a few days. And then that subsides, and then they're left with what's called a vestibular hypofunction. That means on one side, wherever either the left or right, wherever the labyrinthitis or neuritis happen, they are going to have decreased function. So if the labyrinthitis affected the left inner ear, then they now have a left vestibular hypofunction. And so it would be beneficial to go to vestibular therapy after that kind of acute attack, and we work on improving that, which I'll get to. But if you experience kind of this sudden violent vertigo, you're going to make sure you rule out a stroke or a TIA, but it could be something like this. Likewise, it's significantly less severe. In fact, it's not severe at all, but we could have what's called an acoustic neuroma, which is a non-cancerous tumor that develops in the vestibular system. It's very slow growing, but it presents very similarly to a subacute labyrinthitis or neuritis, or in other words, it looks like a hypofunction. So you're going to have a lot of symptoms that are similar to if you had had a labyrinthitis or neuritis. Now, the way we determine what you have going on with your dizziness is you usually go see an audiologist who does testing for you. I don't do that, so I don't have a lot of information on that in this presentation. But if you're interested in what testing they do, I can let you know. But things like an acoustic neuroma, a labyrinthitis or neuritis, those would be picked up by an audiologist in vestibular testing. And so an acoustic neuroma is going to impact balance and your dizziness much similarly to the way labyrinthitis and neuritis would. Okay, so now let's talk about a dizzy episode that is episodic or episode specific. And that would be something like a TIA or a stroke. It's caused by reduced cerebral blood flow, and it can cause lightheaded or dizziness during the TIA or stroke, or after, depending on the area that was affected. We can also have orthostatic hypotension or pre-syncope, which is a drop in blood pressure when moving from sitting or lying down to standing. This can really affect the individuals in the Parkinson's disease progression, is this orthostatic hypotension that may be causing some dizziness with position changes. And then a rare vestibular dysfunction called Maladé-Debarkment syndrome, and it causes or is experienced as a rocking sensation after being on a boat or like a cruise ship, airplane, train, and individuals usually feel worse when they're being still and they improve with movement. So it's kind of counterintuitive in that more movement actually feels better than being still. And they think it's due to a mismatch and a maladaptive wiring in the brain and in the way that the eyes and the inner ear talk to each other. We don't know a ton about Maladé-Debarkment syndrome in the vestibular literature. We're still learning a lot about it. but we can identify it because individuals are kind of opposite from everyone else, right? They feel better when they're moving. Okay, so then finally we look at a dizzy episode that has kind of a vague presentation, right? So individuals who just kind of feel off all the time. We have something called persistent postural perceptual dizziness, or 3PD. It's a chronic dizziness. It's usually brought on by a acute vestibular dysfunction, like a BPPV or a labyrinthitis. And then an individual just doesn't get better, or they just kind of stay dizzy and they kind of develop this persistent, vague dizziness. It's not necessarily a violent vertigo, but it's just kind of feeling off, feeling unsteady, feeling dizzy. And again, this one is believed to be a maladaptation to a vestibular or neurologic event. And then we can have somebody who presents with visual motion sensitivity. And that's dizziness caused by head and body movements. And those individuals usually have intolerance to busy visual environments. Again, that one's similar to 3PD in that we think it's kind of a mismatch in the integration of the visual and vestibular systems. They're just not talking to each other the way they need to. Post-concussion syndrome. So an individual has a concussion, but they don't recover in the way that they should. They kind of get caught in this cycle of maladaptive recovery. And so what I kind of explain it to my patients, and that when you have a concussion, the brain kind of goes into fight or flight, and you get stuck in that fight or flight cycle. You don't kind of recover from the concussion. And so individuals will present with dizziness and eye dysfunction, ocular motor dysfunction, memory issues, difficulty with speech and word recall, maybe imbalance, nausea. It's just, they're kind of stuck in this poor recovery from the concussion. And then we have cervicogenic dizziness, and that's dizziness caused by pain and limited mobility that it's originating from the neck. So the upper neck provides feedback into the vestibular system on where the head is in space. And so if the neck isn't moving the way it's supposed to, then we get altered feedback or inaccurate feedback, which can cause some dizziness. Okay, so now we're talking about vestibular physical therapy. And the goals of vestibular physical therapy, number one, is to minimize vertigo and dizziness. And depending on the diagnosis will dictate how we do that. The three kind of principles of vestibular physical therapy are habituation, adaptation, and substitution. And I'll go over that in the next slide. With vestibular physical therapy, we're trying to work on making neuroplastic changes. So the brain is plastic in that it responds, it can form new pathways and responds to various interventions for recovery. And then finally, we're looking for long-term compensation. So if there was an injury to one side of the vestibular system, then we can't fix that injury, but we can compensate for the loss. And that's going to help an individual be able to function at a normal or almost normal rate as they were before. Vestibular physical therapy is going to work on balance, proprioception, postural stability, and vestibular visual stimulation. We're going to try to get all those sensory systems to talk to each other better, to integrate more, to organize better in order to make long-term changes. So symptom management in PT. So if somebody has blurred vision, a lot of times that's caused by a mismatch of eye and head movement. When we talk about normal vestibular function, it means that our eyes and head are working together. And when we turn our head one direction, our eyes move in an equal and opposite direction and magnitude. And so when we have dizziness with head turns, it means that the eyes and the head aren't moving in equal and opposite directions. And so what we're trying to do in physical therapy is recalibrate that system. It's called the vestibular ocular reflex, and we're trying to get the eyes and head to move together. To move coupled, to move in this opposite direction in the same speed and magnitude. If somebody reports that their eyes feel like they're jumping, again, it could be a mismatch of eye and head movement and or poor gaze stability. So if the eyes aren't stable and aren't working when the head isn't moving, then when the head is moving, it's going to be even worse. So we make sure that we can stabilize the gaze while the head is stable. And then when we move the head, the eyes are moving normally as well. So I see that a lot with vestibular migraine, with post-concussion. The patient has a hard time with gaze stability when their head isn't moving. And so that's where we start first. If somebody's complaining of dizziness with head turns caused by motion sensitivity, that eye and head mismatch that we talked about, or imbalance, we work on the things that I just talked about, but then we also work on standing and walking with head turns, as well as improving the neck mobility. If somebody has imbalance, unsteadiness, frequent falls or near falls, those definitely count. We work on static and dynamic balance exercises. So we want to make sure that you can maintain your balance when you're standing on even and uneven surfaces. And then we want to make sure that you can maintain your balance when you're walking, you're changing directions, you're turning your head on even and uneven surfaces as well. So here are those principles of vestibular PT that I was talking about. So habituation is the process when the brain stops attending to the same unchanging stimuli. So we're desensitizing for an aggravating movement. So if turning your head to the right was really aggravating, we would want to incorporate that in a way that the brain doesn't get aggravated by it, and that you can perform that and it's no longer a threat, essentially. So then if we talk about adaptation, it's a process in which sensory receptors become less responsive to a stimulus that is unchanging. Think about like putting a shirt on in the morning. You put the shirt on and you're aware of it, but then the shirt's on the rest of the day and your brain is not attending to it. You don't feel it anymore unless you pay attention to it again. Your sensory receptors have adapted to that stimulus. And so that's what we do with the vestibular system, is we force the use of the remaining vestibular input to recalibrate the system. That's used a lot with our folks who have a hypofunction. If one side isn't functioning at the same level as the other, but we still have some function there, then we tap into that remaining function to help recalibrate the whole system, essentially. So we're readjusting the vestibular reflexes. An example would be doing head turns with visual fixation, which is called the VOR exercise. Another principle would be substitution, and that's going to be the use of alterative systems and strategies to adjust for permanent changes, like using additional lighting or an assisted device, or maybe if you've got a lot of rugs in your home, maybe taping those down, or if you can, if they're like floor runners, maybe moving those all together. And then compensation, all of these things will lead to compensation, which is those long-term neuroplastic changes to the system to recalibrate asymmetrical responses. So basically we had this asymmetrical or abnormal response. We've gone through these principles of habituation, adaptation, and substitution, and now we're getting some compensation, ultimately to optimize function. That's kind of the big takeaways. We're trying to optimize function with our folks who are dizzy. What can we do to maximize, optimize function? So the top left picture, she's doing that VOR, vestibular ocular reflex exercise. She's keeping her eyes fixed on that black target and then turning her head side to side, trying to keep the object clear while she increases her speed. The gentleman in the top right, he is doing a sit to stand, and he's doing that to habituate if that movement was caused dizziness, like with orthostatic hypotension, then we would do it in kind of a graded manner so that his body would get used to the changes and he wouldn't get such a strong reaction when he went from sitting to standing. Bottom left, he's doing what he or she's doing walking with head turns. And again, we're trying to work on the dynamic balance as well as eyes and head working together. The gentleman in the middle, he's working on static balance. He's standing with his feet together, eyes closed, trying to tap into his balance systems. So we have 3 balance systems: our eyes, our inner ear, and our sense of touch. And when we close our eyes, we take away that feedback. And then when we stand with a narrow base of support like he's doing, we have reduced feedback. And so by doing this, he's really trying to turn up the feedback that he gets from his vestibular system. And then in the bottom right, she's doing a habituation exercise where she's leaning forward and backward, trying to desensitize her vestibular system to that movement. Okay, so treatment. If someone has BPPV, we're going to do a repositioning maneuver. So we've got to move the head and body in such a way that those crystals that were floating through the canals, they go back to where they came from, essentially. Where they reside is kind of like flypaper. And so if we move the crystals through the canals and get them back to their home, they stick. BPPV usually resolves within 3 visits or 3 bouts of repositioning. And with vestibular therapy, we would also address any underlying imbalance issues. There's new research coming out showing a correlation between decreased vitamin D levels and recurrent BPPV. So something to ask your physicians about if you notice that you have BPPV or you have had it in the past, is to see if it's okay to increase your vitamin D. If it's okay with your physician, then it can be helpful in maybe decreasing the likelihood of getting recurrent BPPV. So with individuals with vestibular migraine and Meniere's disease, we treat them pretty similarly. For both those, it's really important that they're managed medically and pharmacologically because that's gonna be really helpful. Basically, the reason that's important is because vestibular physical therapy is going to introduce things that are aggravating and we're trying to habituate and adapt to that stimuli. And if a person is already aggravated and already dizzy and already in kind of a state where they're not at baseline, then they're not going to get much out of it. So we need to get them medically managed so that we can make long-term changes. We're going to do ocular motor assessment and treatment. We're going to work on balance. We're going to work on that VOR that I was talking about, and compensatory strategies or ways to adapt to some of the changes that are happening. And then lifestyle management would be what's listed there: low sodium, minimize caffeine, improve sleep, and manage allergies and stress. The superior canal dehiscence and perilymphatic fistula, those are rare. Conservatively, we can try vestibular therapy to improve balance and postural stability. And we can also try medications. If they get to a point where we're just not making any headway, then surgical interventions are considered. And that'd be done by an ENT. So labyrinthitis and neuritis, initially during the initial attack, vestibular suppressants and anti-nausea medication are really helpful for getting through that. Once you're out of the acute phase, then we want to initiate vestibular physical therapy, tapping into those principles of habituation, adaptation, substitution, trying to compensate for the hypofunction. Do you want to talk about, if you're on vestibular suppressants and anti-nausea medication, when you have labyrinthitis and neuritis, you want to talk to your physician about decreasing that, because if we're trying to improve the vestibular system and we're taking medication that suppresses it, it's going to make recovery, long-term recovery, challenging. Orthostatic hypotension and pre-syncope, biggest thing is going to be medication management with your physician. So talking about, are there different times a day you can take it? Can you, spread out the dosage, things like that. We're going to work on compensatory strategies. Are you dizzy, or is it postural instability? We're going to work on your balance, graded exposure. So sit to stands, or going from laying to sitting, or maybe laying to partially reclined, things like that. Hydration is huge. And then if it's okay with your physician, consider some compression stockings. Following a TIA and a stroke, it depends a lot on what area of the brain was damaged, but a lot of it's going to be that same stuff we talked about: improving your balance, postural stability, making sure your ocular motor function is where it needs to be, and then those principles again of vestibular physical therapy. Mal de debarquement. With these folks, we're going to start with a lot of motion and try to reduce to minimal motion. So graded exposure to something that's aggravating. When we're talking about an acoustic neuroma, that treatment is very similar to a labyrinthitis or neuritis. It presents like a hypofunction, and so we're going to treat it very similarly to that. If it gets to a point where it's continuing to cause issues and folks aren't getting better, then surgical resection may be considered. And folks tend to do really well with that. Sometimes the neuroma can be integrated with the facial nerve. And so when the tumor is resected, folks may have some facial paralysis. And so they can go see a facial therapist, a facial physical therapist as well, to help with that. 3PD and visual motion sensitivity, it's very patient specific. So we really need to find out what is it that's aggravating and how can we adapt to that. A lot of it's going to be the desensitization to visual and head movements, but we're also going to tap into a meditation and sensory grounding, because with 3PD and visual motion sensitivity, the brain is kind of getting inaccurate feedback. And so we do meditation to kind of calm everything down, kind of quiet the system. And then sensory grounding is giving feedback to the brain that you're not moving, even though it feels like you're moving. With post-concussion, we're going to do make sure that ocular motor function is where it needs to be. Again, postural stability, dynamic balance, symptom management. We're going to do meditation with our post-concussion folks as well, and then graded exposure. So a lot of times I will have them do something that is aggravating, but only for a short time, let them recover from that, and then reintroduce it again. And then there's a lot of collaboration with other disciplines with post-concussion, whether it's speech therapy, occupational therapy, neuropsych, a lot of collaboration with post-concussion. And then cervicogenic dizziness, that's going to look a lot like traditional physical therapy, in that we're working on your neck range of motion. We may do manual therapy to improve that. We're going to improve your neck strength and proprioception, and work on your balance and habituation to head and eye movements. So if you find that you are dizzy, first make sure rule out anything really sinister, like a TIA or stroke, or if it's really severe, labyrinthitis or a neuritis. And then you're going to look for physical therapists with experience in treating patients with neurologic conditions, because vertigo is considered a neurologic condition. If you're looking and you see someone who has a neurologic certified specialist, that's even better, because then they have more training in treating folks with neurologic conditions. With individuals who are dizzy, the home exercises are hugely, hugely important. I know you hear that a lot, but my folks who do their home exercises get better so much faster, and they don't have to go to PT as long. And then my little plug is that, a lot of folks don't like to use assisted devices. It can make them feel like, I don't know, but I can understand where they're coming from. But my biggest thing is I want to make sure you can stay as independent as possible.